Every year, more than 3 million older adults in the United States are treated in emergency rooms for fall injuries. Falls are the leading cause of both fatal and non-fatal injuries in adults over 65. Not cancer, not heart disease, but falls. But when researchers look closely at what these patients have in common, the same pattern keeps appearing. Studies show that 65 to 93% of seniors who suffer serious fall-related injuries were taking at least one medication formally identified as a fall risk increasing drug in older adults. These are not obscure drugs with buried warnings. They are medications that multiple large-scale meta-analyses, the American Geriatrics Society's 2023 Beers criteria, and the CDC's own fall prevention program have specifically flagged for seniors. 6 of them are so common that there is a real chance that at least one is sitting in your medicine cabinet right now. I have seen the aftermath of this more times than I can count. A hip fractured in the middle of the night, a head injury from a bathroom floor, a person who walked into the hospital independently and never walked out the same way again. But in almost every case, the connection to medication was never discussed. But I won't allow this to happen anymore. That is why I created this channel, to expose the system and to share what is best for you and your health. Hi, I'm Dr. John. Subscribe and hit like. We're building this to 1,000 subscribers on one principle. The system profits from your sickness, not from you being healthier. In this video, I am going to walk you through all 6 medications. The exact names you will recognize on your bottles, what each one does inside an aging body that makes it dangerous in a way that was never explained to you, the numbers from the research so you understand how significant the risk actually is, and the specific questions you need to bring to your doctor before your next refill. One important disclaimer before we start: do not stop any medication on your own based on this video. Every drug on this list treats a real condition. The goal is not to stop treatment. The goal is to have an informed conversation that your standard appointment was never designed to give you. Now, here is what your body is doing with these drugs that changes everything after 60. Picture your balance system as a feedback loop running constantly in the background. Your eyes track where you are in space. Your inner ear measures tilt and momentum. Your muscles receive signals to adjust. Your brain processes all of it and fires the corrections fast enough that you never notice them happening. A tiny shift of weight here, a micro adjustment of your foot there. That loop runs in milliseconds. When it works properly, you catch yourself without thinking. When it is slowed down even slightly, small disruptions that your body would have corrected automatically become falls. Here is what aging does to that loop, and why it matters so much with the medications we are about to cover. By the time you reach your 60s and 70s, your liver's ability to break down and clear medications has dropped by 30 to 40% compared to when you were 50. Your kidneys clear drugs more slowly too. What that means in practice is that a sedating medication producing mild drowsiness in a 50-year-old can produce prolonged, heavier sedation in a 75-year-old taking the exact same dose. The drug stays in the system longer, the effect runs deeper, and the balance feedback loop, already working with less reserve than it had 20 years ago, gets slowed further at exactly the wrong moments. The step down from a curb, the edge of a rug, the bathroom at 3 in the morning. But here is the detail that multiplies everything: polypharmacy. Most seniors are not taking one medication. They are taking several. The CDC STEADY program identifies polypharmacy as a primary multiplier of fall risk because the sedative and balance disrupting effects compound in ways no single prescription label can predict. With that foundation clear, here are the 6 drugs the research consistently identifies as the most common contributors to fall risk in older adults. The first class is the one I want you to check for tonight: benzodiazepines. Lorazepam, sold as Ativan; diazepam, sold as Valium; alprazolam, sold as Xanax; and the closely related Z drugs, primarily zolpidem, sold as Ambien. These are the medications most commonly prescribed for anxiety and sleep in adults over 60. Across multiple large meta-analyses, they carry pooled odds ratios for falls between 1.42 and 1.57, meaning they increase the odds of a serious fall by 40 to 57%. The 2023 American Geriatrics Society Beers criteria gives a strong recommendation to avoid these medications in any older adult with a history of falls. The reason comes back to that feedback loop. Benzodiazepines slow the speed at which your brain translates a balance signal. I am tipping sideways into a physical correction. In a younger adult, that translation happens fast enough that the correction occurs before a fall does. In a senior on a benzodiazepine, That loop is delayed. Patients describe it as feeling slightly underwater, mentally present but a half second behind the world around them. That half second is enough. And the long-acting versions, diazepam in particular, accumulate in the system over days. A dose taken 3 nights ago is still slowing that feedback loop today. If you see lorazepam, diazepam, alprazolam, or zolpidem on any bottle in your cabinet, and you have never had a specific fall risk conversation with your doctor about it, that is the gap this video is asking you to close. The second class is the one that surprises people the most. Antidepressants, particularly SSRIs like sertraline and citalopram, and the older tricyclic antidepressants, carry pooled odds ratios for falls between 1.57 and 1.68, with some subgroup analyses reaching up to 2.0 in older adults. The 2018 Sepala meta-analysis published in the Journal of the American Medical Directors Association placed antidepressants at or near the top of every risk ranking for this age group. They are among the most commonly prescribed medications in seniors, used not only for depression, but for anxiety, chronic pain, and sleep. 3 mechanisms run at the same time. The first is sedation, which produces the same delayed balance correction we covered with benzodiazepines. The second is orthostatic hypotension. When you stand up quickly, your blood pressure needs to adjust fast to keep blood flowing to your brain. Antidepressants slow that adjustment. For a split second, as you rise from a chair or step out of bed, blood pressure drops, the brain receives slightly less oxygen, and you feel that rush of dizziness, the momentary blackout at the edges of your vision. For a younger person, the adjustment catches up before anything happens. For a senior, especially at night, that moment is when falls occur. The third mechanism is direct impairment of the coordination pathways in the central nervous system. 3 separate risk pathways in one pill. If you are currently on an antidepressant, the specific drug, the dose, and its interaction with everything else you take deserve to be reviewed with fall risk explicitly named. The third class is opioids, oxycodone, hydrocodone, and tramadol. Opioids carry a pooled odds ratio of approximately 1.60 for falls in the Sepala meta-analysis. I want to tell you about a patient I will call Robert, 71 years old, retired engineer, sharp and independent. He had been managing chronic knee pain with hydrocodone for nearly 2 years. His prescribing doctor was keeping his pain at a level where he could stay active, but nobody had ever formally evaluated his fall risk in the context of that prescription. Robert fell getting out of the shower one Tuesday morning. He fractured his wrist catching himself, then fractured his hip on the way down. He spent 11 days in the hospital and 3 months in rehabilitation, and he never fully returned to the independence he had before that morning. When we reviewed everything, the opioid contribution to his balance and reaction time had never been part of the conversation. That question, has anyone talked to you about your fall risk, was never asked. Opioids produce sedation, dizziness, particularly with new prescriptions or dose increases, and confusion in older adults at higher rates because of slower drug clearance. If you are managing chronic pain with an opioid and are also taking anything else that affects the central nervous system, the combined sedative load needs to be evaluated with your fall risk as a named item. The fourth class deserves particularly close attention because many people taking these medications do not fully understand why they were prescribed or the full risk profile. Antipsychotics, quetiapine sold as Seroquel and risperidone, among the most common, carry pooled odds ratios between 1.54 and 1.59 for falls. The Wolcott 2009 meta-analysis in JAMA Internal Medicine and the 2023 Beers criteria both flag them with strong language due to fall and fracture risk. A growing concern in the research is that antipsychotics are increasingly prescribed off-label to seniors for sleep difficulties and behavioral agitation rather than for psychosis. Seroquel in particular has become a widely used sleep aid. The gap is not that these prescriptions are made carelessly. The gap is that when a medication is used off-label, the informed consent conversation is often less thorough. Patients are told it will help them sleep. The fall risk profile, sedation, disruption of motor coordination, and orthostatic hypotension that make nighttime bathroom trips dangerous do not always receive the detail it deserves. If you or someone you love is taking any antipsychotic and has never had a specific fall risk discussion, that is the conversation to request at the next appointment. The fifth class has quietly become one of the most prescribed categories in older adults, and its relationship to fall risk is more nuanced. Gabapentinoids, gabapentin sold as Neurontin and pregabalin sold as Lyrica, have been associated with increased fall risk in many studies. primarily through dizziness, ataxia, sedation, and cognitive effects that can disrupt the balance feedback loop. The Sepala meta-analysis and the 2023 Beers criteria both include them in fall risk guidance. More recent research, including a 2025 study on neuropathic pain, shows a mixed picture depending on the patient profile and what the drug is being compared to. What the research consistently agrees on is that dizziness and unsteadiness are among the most commonly reported side effects in older adults. Gabapentinoids work by reducing the excitability of neurons to calm overactive nerve signals. If you are taking gabapentin or pregabalin and have noticed any new dizziness or unsteadiness, that is a documented pharmacological effect worth raising explicitly with your doctor. Dose adjustment or timing changes can often make a meaningful difference. The sixth class is the one most likely to be in your cabinet right now without a prescription, and the one people most consistently underestimate because it does not feel like a real medication. Go to your medicine cabinet and grab every bottle with PM on the label. Tylenol PM, Advil PM, Aleve PM, Zquil, Unisom, Benadryl. Look at the active ingredients. If you see diphenhydramine, here is what that drug is doing in an older body. Diphenhydramine is a strongly anticholinergic medication. In older adults, anticholinergic drugs produce sedation, confusion, impaired balance, and slowed reaction time that multiple studies have directly linked to falls. The CDC STEADY program lists anticholinergics as a key fall risk increasing drug, and the 2023 Beers criteria includes a strong warning. Recent case crossover studies have confirmed the association. Alongside diphenhydramine, prescription muscle relaxants such as cyclobenzaprine sold as Flexeril carry adjusted odds ratios between 1.35 and 1.42 for falls, and are also included in the Beers criteria. The reason this sixth class matters so much is the access problem. The other 5 require a doctor's signature. This one, you buy yourself without any conversation, marketed as a sleep aid or allergy pill, taken by many seniors who were never told that the same ingredient causing drowsiness is also disrupting the neurological coordination required to stay upright at 3 in the morning. So here is what to do with all of this. The first step is a medication review. A specific, structured conversation with your primary care physician or pharmacist in which every medication you take, prescription and over-the-counter, is evaluated for fall risk. This is not a standard part of a routine appointment unless you ask for it explicitly. Say these words: I would like a review of my medications for fall risk. Bring every bottle, because the research is clear. The risk multiplies with each additional medication. When you have that conversation, 3 specific questions are worth writing down. 3 specific questions are worth writing down. For each medication identified as a fall risk, is there an alternative with a lower fall risk profile that manages the same condition? Is the current dose the lowest effective dose for my situation? And is there a non-pharmacological option that could reduce reliance on the high-risk drug? These are the exact questions the Beers criteria was designed to prompt. The second step is a fall risk assessment if you have not had one recently. The CDC STEADY program includes a validated tool that evaluates your balance, gait, and strength. Ask for it by name and bring someone with you to that appointment. Research shows that seniors attending alone retain less than half the information given and are far less likely to ask the hard questions. Before I wrap this up, I want to ask you directly, of the 6 classes we covered today: benzodiazepines and Z drugs, antidepressants, opioids, antipsychotics, gabapentinoids, and anticholinergic antihistamines, how many are currently in your home right now? Write the number in the comments. The data from fall-related hospitalization research suggests that for most households over 60, the answer is more than 1. Your answer helps the next person watching understand they are not alone. Now, to summarize everything. Falls are the leading cause of fatal and non-fatal injuries in adults over 65. Studies show that 65 to 93% of seniors who suffer serious fall-related injuries were taking at least one fall risk increasing drug at the time of the event. The 6 most common of those drugs, confirmed across the Sepala 2018 meta-analysis, the Wolcott 2009 meta-analysis, the 2023 American Geriatrics Society Beers criteria, and the CDC STEADY program, are benzodiazepines and Z drugs, antidepressants, opioids, antipsychotics, gabapentinoids, and anticholinergic antihistamines. All of these risks amplify with age-related changes in drug clearance and multiply when combined with other medications. These are not bad drugs. They are medications that were studied in older adults, and the data revealed something that most patients were never told. That information belongs to you. A medication review, a steady fall risk assessment, and one additional person in the room at your next appointment. Those 3 things together change the conversation you are walking into. And remember, do not stop anything on your own. Bring this information to your doctor and ask the question directly. Given my age, my other medications, and my overall health, has my specific fall risk from each drug I am currently taking been formally evaluated? If this channel is giving you the kind of specific, research-grounded health information that the industry hides from you, subscribe right now and share with your loved ones so they can benefit from these videos.